small areas of subretinal fluid, I don't know why, but they are very hard to treat. They do poorly, usually on PDT. But of course, if it's a chronic patient, vision is bad or deteriorating, fellow eye is bad, you see that the subretinal fluid increases and is moving to the fovea, I would definitely try to treat.
Yeah, same for me. And if there are large areas that can really affect the paracentral visual field, I would also consider it. But it depends, of course, on whether or not you have reimbursement. In the Netherlands, we get all the treatments reimbursed, so it's a very luxurious situation. So I don't want to act like it's very easy if that's not the case in another country. But yeah, it depends also on that, of course.
Okay, thank you very much.
Going back to eplerenone, in the Vichy trial, the original protocol was just to include treatment-naive patients. And what the investigators found was after 6 months, the recruitment was very poor. So they changed the protocol to include previous PDT patients. And in a post-hoc analysis, they found there were more PDT patients in the control group than in the eplerenone group. So what do you have to say to that?
I would like to see more data.
This fact is not in the main paper, by the way. It's in the supplementary paper.
Yeah. Yeah, but let's see. The subgroup analysis to try to squeeze something out further is always a bit tricky. If there are no more trials, I'm very skeptical, also based on the SPECTRA trial with regards to using eplerenone as a primary treatment. But everybody is free to still use it. But I just want to stick to the most important evidence.
Thank you.
Morning. My question is for Suzanne about the different pathologies for the differential diagnosis. And I found that all these pathologies, in these all pathologies, the choroid is normal or even thin, like in myopia. So I don't understand what is the need for differential diagnosis.
Well, the need is that people are aware of the fact that when there is presence of subretinal fluid, but like you mentioned, the choroid appears normal or what you expect for the, let's say, the refraction, you have to think again if it's really central serous choroidenopathy that you're looking at. Because if you just, I think we get referred a lot of central serous choroidenopathy patients, and I think Camille does too. And you sometimes look at them and like, why have you been looking at this? This is like, for instance, the hemangioma, or, you know, it's, so people should be aware of the fact that other diseases may look the same if you're not aware of what you have to look for.
It has immediate prognostic and therapeutic consequences, so that's why it's so important.
Central serous does occur in myopes, though. It's rare. And the interesting thing is that these choroids in the myopes are actually thicker than you would expect for the degree of myopia.
There was one question, online question about testosterone. So if you should look for testosterone problems in CSC patients, I don't think that's the case. But what I did see in a few patients who had a gender transition, so had a testosterone supplementation, that they developed CSC. So that there is an association with testosterone supplementation, it seems, for instance, in gender transition patients who can have CSC. So it may even trigger CSC in those patients.
Yes, what about melatonin and DSR?
As a treatment, you mean?
Yeah.
There's too little evidence for that. So we need studies. Yeah. Difficult to make a prospective randomized control trial, but yeah, there's not enough evidence for that, unfortunately.
Thanks, Suzanne and Camille, for some wonderful talks. I've got a couple of questions, and I don't know whether there's any answers, but I'd be very interested to hear your thoughts. So the first is, we see steroids as being a very potent risk factor for central serous choroidenopathy, and yet we very rarely see CSC induced with local steroids, whether it be periocular steroids, intravitreal steroids. Any thoughts on why that might be the case?
Well, I have some thoughts, but indeed we need studies and evidence for that. It might, for instance, be that there is a difference between the levels with intraocular steroids and systemic steroids. and that if there's a disbalance there, then that's what's causing the central serous keratinopathy. So not the increasement of local steroids, but an increase of systemic steroids.
That's very intriguing. Yeah, I'm also not sure why that is. I mean, just
It's just a
sniffing some
thought
steroids
that-
can be enough to cause CSC, but well, how often do we see CSC with patients who had steroids after cataract operations, etc.? It's quite intriguing.
Puzzled me for a long time.
Yeah.
The second question is, there's some evidence with, when we look at neovascular AMD, that subretinal fluid can be protective against atrophy. Now, in central serous, our aim is always to dry out the fluid. Is there any studies looking at atrophy rates with drying up of subretinal fluid?
Yeah, so there was the study that I just mentioned after fovea involving PDT. So with 2 years of follow-up, we just found an improvement and no atrophy. And we're actually on the verge of publishing 5-year follow-up data in terms of atrophy after PDT, for instance. And, well, it's not published yet, but I can tell you that it is almost non-existent.
But I also think that maybe, the choroid neovascularization in AMD, as is suggested, maybe a rescue mechanism for what's the focal changes there. And that's not the case in central serous keratinopathy. So the presence of subretinal fluid in CSC may actually be different over time than subretinal fluid in AMD.
My question is, why do some patients go through the full spectrum of disease while some patients resolve spontaneously? Do you have an answer to that?
Well, I think it has to do with, well, I don't have a good answer, but I think one of the key factors will be the amount of choroidal changes. So we're just publishing a few things on that right now. We just published a paper and coming up with another one where you had, so I told you about the mid-phase ICJ abnormalities, right? So if you look at an acute CSC patient, they generally have one area of indistinct leakage. And some have multifocal, but some have diffuse leakage. And we are trying to coin the term focal indistinct hyperpermeability, FISH, and diffuse DISH. And so the patients that we saw with the diffuse leakage, they have more extensive RP abnormalities, they have lower retinal sensitivity on microperimetry. So it seems to me that these are the more severe venous overload choroidopathy patients. And maybe there are also RPE determinants in those patients which we cannot really point out that also play a role. So it might be the interplay between the choroid and the RPE, I think.
But it's the minority of cases, right? If you would say really acute case that eventually goes into a very chronic case, it's what Daniel Moabati studied.
Yeah.
It's very rare.
Yeah, that's interesting. That's a very interesting point, Suzanne. So we looked at it too, indeed. So the patients who presented with very severe chronic disease, many of them didn't have a history of acute CSC. And we found very few patients with acute CSC who developed these very severe chronic phenotypes. So there is almost some kind of distinction between maybe even two groups. But when we looked at the genetics, it was very similar between the two. So there's certainly also overlap. So it's really intriguing.
Thank you.
Comparing half dose and half time PDT, I'm aware they're equally effective, but what about security? Did you notice any difference?
No, there doesn't seem to be difference. I would recommend half dose for two reasons. If you're allowed by your country, I mean, we share one vial with two patients, so it's cost reduction. You have to inject less drug in the patient, so less risk of side effects, although the risks are already very low. But in terms of efficacy, it seems that at least half dose and half fluence seem to be equivalent. Half time is a little bit less publications on that, but probably also the same. But personally, I would, for the reasons that I mentioned, choose half dose.
Yeah, so when I used to do PDT, my machine, well, it actually only allowed me to do half time, and it was very successful. So like in the same order as from the studies published.
Thank you for your talks. I have two questions, if there's time. Well, the first question is, when do you start treating? How long do you wait? I know there's no concrete answer, but let's say it's a naive patient. You never had that patient before. It's not a chronic case.
in acute CSC, a typical, let's say, a younger male acute CSC who seems to have not too many RPE changes or no RPE changes in just one leak, I would definitely wait. A high risk of resolution. If there are already signs of chronicity, so more RPE changes, also the retina has more accumulations below it, I would definitely treat as quickly as possible. But in the Netherlands, we have so much experience now that we are really prone to treating early. I'm afraid that if you wait too long, you can have this gradual decrease, and the changes in the choroid might also become more irreversible, but there's no good proof for that, so this is just speculation on my side.
Wait about 3 months just for the first follow-up and see what happens, or a bit more often?
Seems fine to me.
Yeah. So it's interesting because this lack of Visidyne, it made us, unable to treat central serous patients. And of course, we don't have long-time follow-up on these cases, but I would usually treat within the first 3 months if I would see them or get them referred. Now I had to wait 6 months or longer, and the final visual outcome appears to not be very different.
Yeah. And the other question is, you mentioned that it's mostly type 1 choroidal neovascularization in these cases, although it's a secondary to another retinal disease, and more often it's type 2 membranes that we see secondary to other retinal disease. Is there a reason for that? That is type 1 and it doesn't break through the RPE?
Well, I think it's because of the main problem is in the choroid, so that's where the neovascularization occurs too. That would be my
Yes, you see it, you mainly, in my experience, you see the type 1 MNV mostly on top of the thinned choroid capillaris. So there's a big pachyvessel that compresses the choroid capillaris. There is ischemia there. So that's where gradually and very slowly there is this really shallow type 1. And that can even be relatively inactive. I think that's possibly a reason. So there's just not this major breakthrough through the RPE. It might actually also be a compensation mechanism as a pseudo choroid capillaris that grows on top of it.
Thank you very much.
Thank you for the interesting session. For the chronic patients who don't have a complete resolution of the fluids, what time do you leave between two PDT sessions? And is there a limit of amount of sessions you can?
So I would not wait. If it's a clear chronic case, and it depends also on the multimodal imaging, I would just plan the patient for PDT. And with regard to the amount of PDT, the first punch is the best. So you really want to get rid of the fluid after the first PDT. We found in the PLACE trial the patients who needed a second PDT was only effective in 30% of the cases. So if you do PDT, and it's really a typical CSC case, and they don't dry up, redo the FFA ICGA and have a look if you might have missed an area of leakage. And those patients will be quite prone to responding to the second PDT. But if not, in my experience, you're in trouble, because they won't respond to anything. And of course, they can wax and wane. It's a difficult case then. What do you think, Suzanne?
Well, I was actually wondering what you would do in a case that responds well to PDT and then has a recurrence and over again. How often do you treat?
I've treated, I think, we're actually also looking at the multiple PDT patients with regard to maybe atrophy development, which also doesn't seem to be a big problem, I think, but let's see. But we treat up to 3 or 4 times. But in my experience, the chance of it responding is not super high.
Well, what I mean is if they had an initial good response to PDT and then within a couple of months or years they have a recurrence.
I redo the FFA ICGA and then try again. But it's not the 80% response rate that we find in the first time PDTs that we see then.
Yeah, so there are many people that say you can only treat one eye 3 times with PDT. I have a couple of patients that only have one eye and have a chronic central serous with subfoveal fluid. They respond beautifully to PDT. And of course, I look at the ICG. If the ICG area where you want to do the PDT is like really black or ischemic, I'm reluctant to repeat the PDT right there. But if not, I will just retreat. And I have a couple of patients that I've had done, let's say, 6 PDTs in one eye without any problems. Thank you.
Multimodal classification of
One last question, yes.
is multimodal classification of CSC clinical relevant?
Yes, there are some papers out there that suggest that a multimodal classification, which was done by the International CSC Classification Group, might have prognostic implications. And I think anyway, multimodal imaging, as I also told you about the leakage pattern ICGA, can have really immediate clinical implications with regard to severity and maybe even response to treatment. But there's no more data needed on that. Thank you. We have to stop the session now. We're very strict on time. Thank you so much for the lively discussion, for your presence here. Thanks, Suzanne.